Okay, I'm sure you are super confused or somewhat confused regarding the 2021 E&M guidelines. For most of you, today is the first day of 2021 when you're seeing patients and you are applying these new rules. I'm going to go over the 2021 E&M guidelines, what you need to know and how they will affect your practice. It's a webinar that was given by the AUA back in early December, and they wrote down the Zoom chat Q&A summary. And I'm going to go just hit a few highlights. That seems to be a recurring theme or a question about the 2021 E&M guidelines. So first of all, before we get started, I just want to let you know that this applies to everybody, okay? Applies to all payers, not just Medicare, not just Medicaid. This is a CPT change and not just a Medicare or Medicaid change. Now, your private payers may decide that they don't want to use these guidelines right away. Hey, you know what? If your private payers have special guidance for you, by all means, follow their guidelines. But as it stands, it is applicable to all payers. Not only that, the payers that are using electronic data interchange, this is actually a HIPAA requirement for them to be compliant by using the latest CPT guidelines. So this is an across-the-board change. It is not just for Medicare or Medicaid. Let's get that straight. Okay, number one. Number two, when it comes to coding and billing in 2021 today, you code either by medical decision-making or by time. For most of us, it is much more efficient to code based on medical decision-making than based on time. Now, there are instances where we have to do our coding and billing based on time, especially for those complex, prolonged prostate cancer discussions that you usually hold at the end of the day or at the end of the morning clinic. Those are the times where time-based billing and coding would be applicable. Otherwise, for most of us, billing based on medical decision-making is the way to go. And if you disagree, please let me know in the comments. Now, when it comes to medical decision-making, you need now in 2021, today, you need 2 out of the 3 elements to code for a level. What are the 3 elements? One is problem, not diagnosis, not the number of diagnoses, but number of problem, not diagnoses, okay? Number one. Number two, the second element is data, okay? So you got problem, you got data, and then the third section is risk, okay? So you need to satisfy 2 out of the 3 to reach a certain level. All right, so that's kind of like the global overview. If you have any comments or questions, leave them below. I'm gonna go and kind of go over the some of these questions here. Question number 8: medical decision for sterilization consultation. So in the past, I mean, I did a YouTube video. You can find it. Why is vasectomy in 99204 back in just a few days ago, right? 1995 rules. You could justify a level 4 new patient for a vasectomy consultation or vasectomy visit, new patient. However, unfortunately, in 2021, that's only going to be a 99203 because you can't have a problem that's going to be high enough. It's either a stable chronic illness, which will only give you a level 3, or it's probably an acute uncomplicated. So that's also only going to give you a level 3 when it comes to the element problem. Okay, so that's the highest that you can get. Based on, I guess you can, I don't know, a healthy young guy typically coming in, they're usually not coming in with a lot of data for me to review. So reaching a level 4 on data is probably going to be impossible. And when it comes to risk, certainly if a vasectomy is on par as a diagnostic endoscopy, which is a level 4 when it comes to risk. So when it comes to the risk section, you can certainly reach a level 4. Data is going to be very difficult, and a problem is only going to get you a level 3. So a 3, a 0, most likely, and a 4 is only going to give you a level 3 when it comes to medical decision making for sterilization consultation. Okay, let me go down to number 10. Does a parent of a pediatric patient count as an independent historian? So in this instance, we're talking about the data section, because in data you have assessment requiring an independent historian. So if you reach that, it could be a category 1. It certainly gives you a level 2. And if you have assessment requiring an independent historian, you need only one of these 2 sections. And if you have that, that'll certainly give you a level 3. And when it comes to independent interpretation, assessment requiring an independent historian, that only gives you 1, and you need at least 3 or more to reach that category 1 to give you a level 4. So unfortunately, that is how this particular area is played. So we're talking about the data section relative to assessment requiring an independent historian. The answer that was given, does a parent of a pediatric patient count as an independent historian? It definitely does. And that is, if you look at the AMA interpretation, and that is actually the intent of this particular data section when you're counting for data and category. When you have a parent of an infant, it is an independent historian, and you would count that as assessment requiring an independent historian relative to data. So I'm going to, because Dr. Rubenstein's response was that I consider parents of an infant to be the historian, not an independent historian, because the infant would not be able to give their own history at any time. However, a teenager who refuses to answer questions can have their parent as an independent historian. But if you look at the AMA interpretation, having the parent being the historian counts in the data section as an assessment requiring an independent historian. So you would count that for category 1, and category 1 for a level 2, 3, and 4 in the data section. Okay, moving on. Number 14 here. Is a refill of a medication, like the patient is on like Flomax or Viagra, drug management, and would that be a level 4? And Edna Maldonado says, doing refills and drug management does not automatically give you a level 4. Dr. Rubenstein says, it is based upon medical decision-making. If in the course of the discussion, the patient is presented with the options that are discussed, such as surgery, changing medications, staying on medications for their condition, and after listening to the pros and cons and risks and benefits of the options, that the patient remains on the same med, then that can count as a level 4 risk. So it's a little bit nuanced, but it's very actually pretty straightforward. So is refill of a medication like Viagra or Flomax drug management, would that be a level 4? So it's a level 4 risk, okay? Not a level 4 E&M visit. It is a level 4 risk. And level 4 risk is prescription drug management. I can't imagine refilling a patient's medication without considering whether or not the medication should be continued, whether it's appropriate to continue that medication. So in my mind, anytime I add a new medication, change the medication, refill the medication, give the patient a sample, that is prescription drug management. There's no if, ands, or buts, okay? I'm considering the patient, whether or not the patient is a candidate for continuation of the medication, including refill of the medication. So in my mind, that is prescription drug management, and that counts as a level 4 when it comes to risk, okay? I think they're making it a little bit more complicated than it is necessary. And I disagree with with Edna that doing refills and drug management does not automatically give you a level 4. Certainly, it doesn't give you a level 4 visit, but that's prescription drug management. That's a level 4 risk. Okay. And number 15, sterilization level of risk. Okay, so in this case, somebody said that, remember, vasectomy is a major surgery, not a minor surgery due to its 90-day global, the exact definition of a major surgery. And Dr. Rubenstein's response is, no, that is not the definition of major surgery. And I would agree with Dr. Rubenstein. Just because a procedure is deemed as a 90-day global does not mean that it is major surgery. Dr. Rubenstein continues and says that while most major surgeries are valued with a 90-day global, not all surgeries have a 98-day global, and having a 90-day global doesn't make it a major surgery. And I completely agree. Some minor surgeries have a 90-day global. This is a minor surgery. It can be a level 4 for risk if there's specific patient risk above and beyond, such as bleeding diathesis. But it is unlikely that the patient overall will reach a level 4, as 2 of the 3 categories need to be level 4, kind of like what I discussed earlier. I don't see getting there for diagnosis or data as a second category reaching level 4 on a typical vasectomy patient. And that I would have to agree. Okay, let's see. And by the way, having a 90-day global does not necessarily mean that is major surgery. I think that's a common misnomer somehow that is out there. Can you imagine a hydrocelectomy which has a 90-day global? Would you consider that a major surgery? No, that is definitely not a major surgery. Okay. Number 25. I'm going down to number 25. Under the new coding, do new and established patients only need 2 of 3? Okay, so under new coding, it doesn't matter if it's a new or established patient. It is, you only need, so if you're going to be billing based on medical decision making, you only need 2 elements out of the 3. So again, 3 elements are problem, data, and risk. Okay, you just need 2 out of 3 to reach a level. So it doesn't matter if it's a new patient or established patient for the coders and billers. It's a lot easier for you nowadays. Thank goodness, because you can automatically crosswalk. If you erroneously build a level 3 established, you can automatically crosswalk that over to a level 3 new patient without having to consult your physician in 2021. So that is what is so cool about the new rules. Okay. Let's see, number 26. Is ureteroscopy considered minor surgery? Okay, so it is minor, but when you're looking at the 95-97 table of risk, diagnostic endoscopy is a level 4 risk. So if you look back at the 95-97 guidelines when it comes to risk, diagnostic endoscopy is considered level 4, moderate risk. So when it comes to ureteroscopy, when it comes to cystoscopy, that's considered diagnostic endoscopy when it comes to the relative risks, and that's a level 4 risk element when you are talking about the risk section. All right, number 26 we went through. Let's go down to number 53. There are a lot of questions. Okay, number 53 is, if a patient is seeing you for stable BPH and he comes in for refill of his tamsulosin and yearly visit, would that be automatically billed as level 4 because of the prescription? And Maldonado says, no, I agree. Dr. Rubenstein says, no. One chronic problem is a level 3 diagnosis. Refilling medication doesn't make it a level 4, which I disagree, but managing meds does need medical decision making. Okay, so stable BPH comes into a refill for Flomax. Okay, stable BPH, stable relative to you, the patient, and also relative to you. Okay, it is important to know that if the patient is still having really high AUA symptom score, but the bother score is 0, just because the patient feels like, hey, I'm okay, I can deal with this, it doesn't mean that the patient is at therapeutic goal. And that therapeutic goal is dictated by you, the practitioner. Okay, so let's just say in this instance, the patient's happy, the AUA symptom score is low, you are happy, you think the patient is at the therapeutic goal. So that will be a stable chronic illness, and that will be a level 3, okay, when it comes to problem. Now, if you go to the risk section, discounting data, because that's all that I'm presenting in this scenario. So that's a level 3 stable chronic illness, okay? When it comes to risk, you are managing prescription drugs, all right? You're managing tamsulosin in this case for the annual visit. So it's a stable chronic illness, and then you are managing medication, prescription drug management. So you have a level 3 and a level 4. So that means the maximum you can bill in this situation is a level 3. Now, let me show you something that is interesting. If you look at the cheat sheet given to you by the AUA and documentation requirements, you may have gotten this through the AUA University. And if you are just looking at this particular section right here, all right, you are going to be missing out on a couple of nuances. See right here, level 3 level 3 E&M visit, low stable chronic illness or acute uncomplicated illness. What is missing in this section is that if you have 2 self-limited or minor issues that you are managing, that pushes you to a level 3. Because if you just have one self-limited or minor problem that you're managing, for instance, like a minor testicular trauma or maybe pearly papules on the corona, near the corona of the penis that you are seeing for the patient, if it's just one problem, one self-limited or minor issue, that's only level 3. However, what is not indicated in this handout by the AUA, if you're managing 2 of these self-limited or minor issues, that bumps you up to a level 3 problem, okay? Now, the other thing is level 4, moderate, right? According to the AUA handout, one or more chronic illness with exacerbation, undiagnosed new problem, acute illness or systemic symptoms, acute complicated injury. So that gives you a level 4 problem. What is missing in this section is that if you have 2 stable chronic illnesses, so 2 stable chronic illnesses pushes you from a level 3 to a level 4 problem, okay? That is what is missing in this handout, okay? So yes, it's a handy tool, but you may be missing out if you don't understand that having 2 self-limited or minor goes from a 2 to a 3, and having 2 stable chronic illnesses pushes you from a 3 to a 4. And what's a couple of stable chronic illnesses? Let's see, do I have an example? Okay, I'm just going to come up with one. So let's just say that you have BPH that is stable and you are prescribing medication. This is a chronic BPH patient, stable by your standards, stable by the patient's standards, and you are managing the patient for recurrent urolithiasis, and you are prescribing, I don't know, hydrochlorothiazide or maybe providing some counseling. So you have stable chronic illness. One of them is BPH, and the other one is personal history of urinary urolithiasis. And you're managing both of these chronic stable illnesses. That moves you from a level 3 if you're just managing one. If you just have one stable chronic, that's only a level 3 when it comes to risk. Now you're managing 2. That pushes you from a 3 to a 4 when it comes to problem. Okay. And of course, if you have a prescription medication, that pushes you to a level 4 because of prescription drug management. And that's an easy 99214 in this case. But if you just look at this particular handout from the AUA, you will be missing out because nowhere in this section here tells you that when you have 2 stable chronic illnesses, that counts as a level 4. Okay? So understand the nuances. I'm sorry, when you have two of these chronic, when you have two chronic stable illnesses, that gives you a level 4. But if you have just one, that's only a level 3. But anyway, that is not indicated in this. That is not indicated in this handout. So if you have two stable chronic illnesses, again, you have two stable chronic illnesses that you're handling, that bumps you from a level 3 to a level 4 when it comes to problem. That is not indicated in this AUA handout, okay? And also, if you have two self-limited or minor, okay, such as two of these level 2 straightforward issues that you are managing, that bumps you from a level 2 to a level 3. Again, not indicated in this particular handout. So I think it's important to look at the actual AMA guidelines, the handout, understanding that. I am what I'm doing is I'm using the painter, the wall chart. So I'm talking about the problem section. I'm looking at the data section, and then the risk section is pretty easy. The risk section is really just continuation of what we've been using in 97 and 95, with the addition of social determinants of health, which bumps you to a level 4 when it comes to the data section. So data section, not much change in 2021. The major changes are in the problem section. The major changes are in the data section, and also how time is counted nowadays. Also, there's the G2211 has been postponed until January 1st of 2024. So we will see what happens in a few years, whether that 0.33 work RVUs will do any good for us. Okay, I think I have one more, and that is number 54. I just want to make sure I understand correctly. There's no more counting how many diagnoses. Yes and no. So you guys just heard me say this. Pound this in your heads. Typically, there's no more counting of problems, except when you're dealing with two self-limited or minor issue, that bumps you from a level 2 to a level 3. Or if you're dealing with two stable chronic illnesses, that bumps you from a 3 to a 4. So in those two instances, you do count problems, and it does matter when it comes to the problem, when it comes to the level relative to the problem element in medical decision making. Okay. Number 54. No, it has never been. Miss Edna Maldonado says no, it has never been counting diagnoses in a medical necessity and specificity. Well, in 95 and 97, it has been and has always been about counting the number of problems. And yes, of course, medical necessity is the overarching criteria on how we bill. Dr. Rubenstein says, correct, no more counting diagnoses. Well, except for two chronic conditions is counted more than just one. And I think what he's trying to say is two stable chronic illnesses moves you from a level 3 to a level 4. But it is never made clear, and I think you guys who are, and gals who are sophisticated and are E&M geeks, you probably want to know the nuances. So yes, most of the time counting problems don't matter now, except in two instances, except in self-limited or minor, and except in stable chronic illnesses. If you have two of those, then it bumps you from a 2 to a 3 and a 3 to a 4, respectively. Do you need 2 out of 3 columns or 3 out of 3 for new patients? I don't know what she's talking about there, because you no longer need, I mean, in 97, 95, just a few days ago, in 2020, you would need 3 out of 3 components if you're billing if you're billing based on component. But that's back in the old days. All right, 3 out of 3 for new patients. That's back in the old days. It does not apply in 2021. And Dr. Rubenstein says 2 of the 3 medical decision making columns. Yes, you need 2 of the 3 elements in medical decision making when billing for a level in 2021, which means today. Kelly says, this is an important video you are doing. Cheers. You know, I'm just going over these questions and there's just so, unfortunately, it is a little bit nuanced and you can't just give these short answers if you want the audience to really understand. And I'm empathetic to my audience and I want to make sure people really understand this stuff because you're not just learning this once and you're using it for 2021. This is probably going to go on for until definitely beyond my retirement. So for some of you who are starting out, you are going to be using these rules for a long time. It would behoove you to fully understand, and I'm going to say this again, exploit these rules to your advantage. I gave this example before. When Trump and Hillary were debating back in 2016, it came to fore, Hillary said that, you know what, in one of the years, you paid 0 taxes. And Trump's response was, that's because I'm smart, okay? Whether or not you agree or disagree, it doesn't matter. I want to know, my goal is I want to exploit the rules like he does, like we all do when it comes to taxes, right? You're using the deductions to your advantage. You're not doing anything illegal. You're not doing anything wrong. You're simply using and applying the rules given to you. So in the situation between Hillary and Trump, yes, he is smart in being able to usurp and utilize the rules to his advantage. And that's exactly what we're doing when it comes to the E&M 2021 rules. Anyway, Jennifer, there used to be a section for requesting medical records to count as a data point. Has this gone away? I do not see any requesting medical records as a data point, but there is a review of notes that counts as a category 1 point. And it depends on which level that you're shooting for. It could be, for instance, if you just have 1 point and you have review of notes from an outside physician, that would definitely reach a level 2 for you. And if you review a note and review a unique test, and that gives you 2 points, boom, that's a level 3 when it comes to the element data, okay? So no, there isn't any more requesting medical records count as data point. Michael, hey, John, thanks for the video. The way I understand it, anytime I refill meds for a patient with 2 chronic illnesses, is that a level 4 visit? I see that I'm not going to refill without evaluating effectiveness, etc. So 2 chronic illnesses. So it could be, Michael, you just need, if you're dealing with 1 chronic illness that is getting worse, for instance, BPH that is not meeting your therapeutic goals, okay? Your therapeutic goals, not what the patient thinks, but your therapeutic goals. If the patient is not meeting therapeutic goals and you change medication, you have prescription drug management, that's in itself 1 problem that is getting worse, 1 chronic with exacerbation. All right, so that's a chronic issue that is getting worse, no longer well managed by medical therapy, and you manage the patient with prescription drug management. That's a level 4 in the problem section and a level 4 in the risk section. That automatically gives you a level 4. You do not need 2 chronic stable illnesses. You just had 1 problem one chronic problem that is getting worse. However, in the situation that you are describing here, you have 2 stable chronic illnesses for which you are prescribing or managing with a prescription drug medication. That's a level 4 because you have 2 stable chronic illnesses that gives you a 4 in the problem section. And then also you have the risk section, meaning prescription drug management. That's a level 4. So you have a 4 and a 4. You need 2 out of the 3 elements in medical decision-making, and that's how you reach a level 4 in your situation. Michael, yes, true. I mean stable chronic. So if you have two stable chronic problems for which you are managing the patient and using prescription drug management, that's going to be a level 4 when it comes to medical decision making, billing based on medical decision making, because you have, again, two stable chronic illnesses, which you're not going to get that. You're not going to get that information from this handout by the AUA. Okay. Nowhere here. Well, actually, maybe here. One or more chronic. Well, no, actually, no, it doesn't say it. It says here one or more chronic with exacerbation. Nowhere in level 4 in this handout from the AUA does it say that two stable chronic illnesses will give you a level 4. So you would be missing out if you simply took this handout and went with it. You would be missing out on possible level 3 and level 4 by dealing with two self-limited or minor, or one stable chronic illness. Two stable chronic illnesses. For those two situations, you will be missing out on level 3 and level 4 problem sections, respectively. Okay. Michael says, great, thank you. Going to be billing a lot more for return visits. Also, food for thought, make all patients bring their discs with images, get you a level 4 data when you look at it. I've been doing that. Fortunately, I've been doing that for years. And one easy way to demonstrate that you actually looked at the images, typically you're looking at a mass or a stone, right? You just put a cursor over the mass or the stone. Typically, that is never reported anywhere by the radiologist. I don't know why. Maybe they're just lazy. It doesn't gives them any money. I don't know what. But anyway, when it comes to looking at the actual images yourself, just simply take a cursor, a region of interest cursor over the mass, and measure the attenuation reported in your assessment and plan, and boom, no one can dispute that you actually looked at the images yourself. What I've been doing for many, many years is that I have a section in my, believe it or not, in my history of present illness, that says data reviewed, and under that data review will be imaging reviewed. So I specifically mention exactly what images that I reviewed. It could be an ultrasound, it could be a renal ultrasound, scrotal ultrasound, it could be a CT abdomen and pelvis. I indicate what I reviewed, number one, there, the actual images, and number two, I will often just simply comment on my findings when I put that ROI cursor over the mass, over the suspected stone, or the suspected mass, or the stone, and I have an attenuation reading, and that, I mean, there's no disputing. Anyone who audits your chart will be able to look at that and say, yep, you definitely looked at the images yourself. Jennifer says, I know we have talked a lot about established patients, but for new patients, since the problems are new to us, if they are new and requiring further workup, will that start out as a level 4? No. Okay. It's no longer new to you or the patient. It's whether or not this is it's a chronic problem, it's an acute problem that is uncomplicated. It doesn't matter. It doesn't matter if it's new to you. If it's a chronic problem with exacerbation, that's an automatic 4. It doesn't matter if it's a new problem to you. Okay. I know in the past we used to look at a new problem requiring additional workup, being in level 4 automatically. That is no longer the case, unfortunately. It's all about the acuity and complexity of the problem, with a couple of exceptions where you add up the two self-limited or minor, or two stable chronic illness, where you would get an additional level bump in those situations. But overall, when it comes to the problem section, it is all about the complexity and the acuity of the problem. You no longer are adding up problems. You no longer are adding up whether or not this is a new problem to you or anything like that. It's more about the expected course of the problem. For instance, an elevated PSA will be an undiagnosed new problem, all right? A problem in the differential that represents a condition likely to result in high-risk morbidity, such as cancer, or it could be prostatitis, or it could be someone who just aggressively rode a bicycle right before the PSA test, or maybe the man engaged in sexual activity. So you're looking at the diagnosis list, and you're looking at the differential, and this is going to be obviously a undiagnosed new problem that is presenting to you, and that you're going to have to evaluate. Now, not everything is going to fit into these categories perfectly, but I think by applying some general principles when it comes to the problem and the complexity, you should be able to come up with a reasonable level relative to the problem section, problem element when it comes to medical decision making. Anyway, I ramble long enough. I hope this has been helpful. Believe it or not, I've been out of commission for several days because of the flu, COVID-19 negative. Woohoo! Anyway, received my COVID-19 vaccine number 1 yesterday. Very, very excited to finally put all of this behind us so that we can move on. I hope everyone is staying nice and healthy, and make sure that your staff is also staying healthy, because we were facing an issue where a few of my staff members are out, 2 with COVID-19 and 1 with the flu. So that is greatly impacting on my ability to see patients, which is fine. I love the time off and being able to make videos like this. Otherwise, I normally don't have the time to do so. All right, questions or comments, leave them below. Oh, wait, one, Shoe Pan. Thanks for the live stream, John. Sorry if someone asked this. For private payers, do we document according to the new formatting changes, or is there something else that we need to be aware of? I mentioned this at the very, very beginning of the video. The CPT changes are applicable to everybody, not just Medicare, not just Medicaid. So that it came from the CPT. So it is applicable to everybody. And number 2, for those payers that engage in electronic data and electronic data interchange, it is actually a HIPAA requirement that they follow and use the latest CPD guidelines. So I answered that I mentioned that at the very beginning. But anyway, I hope this has been helpful, and please stay well, stay healthy, and enjoy the 2021 changes. Lots of changes, lots of excitement. And I'm sure we will get further clarification from the AMA as more and more people ask more nuanced questions. And there will be definitely a lot more answers coming down the pike relative to data. You know, my questions are like, okay, well, if I order a CT scan for which my entity bills for the TC, but then somebody else bills for the professional component, can I still count for interpretation of the data or review of the data when the patient comes for follow-up? So, you know, these are kind of the nuanced questions that I don't think anybody has a clear answer for. So if you want, you can play it safe by not counting it. But I think if you're not billing for it for the PC component, I personally think that you should be able to bill for the review of the data, because although you ordered a test, you didn't really get paid for the PC component. But anyway, that is pure conjecture. I can't wait for the clarification from the AMA regarding this. Just like anything else, it is just a lot of questions. Sometimes it brings up more questions than answers. And even though they try to do the administrative simplification, patient care over paperwork, sometimes even despite the greatest intent, we still are dealing with administrivia. So, all right, any comments or questions, feel free to leave them below. I don't claim to have all the answers, but I've attended enough seminars, read enough documents, viewed enough YouTube videos to have some perspective regarding the 2021 changes. Stay well, take care, bye-bye.